The following podcast is part of a certified educational activity titled Alzheimer's Disease Neuroradiology Case Conference, Mastering the New Frontier in Diagnosis and Treatment. Access the entire activity and complete the post-test at peerview.com/CEH860. Downloadable slides and practice aids are also available.
Hi, everyone. Good afternoon. Dr. Chiang and I will be presenting this Alzheimer's Disease Neuroradiology Case Conference. I'll start with an overview and focus on molecular imaging and specifically amyloid PET in clinical practice. And then Gloria will take over and discuss ARIA management and treatment monitoring. I think we can go ahead and get started. And like I said, I'll just start with molecular imaging and specifically amyloid PET in patients presenting with cognitive impairment. So we are all aware of amyloid-targeting therapies that are currently on the market available for treatment of patients with early Alzheimer's disease. And in order for patients to be eligible for treatment, all of the patients need confirmation of AD pathology that is biomarker-based, either via CSF or by molecular imaging, meaning PET. So radiologists, neuroradiologists, and nuclear medicine physicians really need to be ready to meet the increased demand for both MRI and PET in patients in this landscape. Amyloid PET is still considered the gold standard for confirming amyloid positivity. And meanwhile, as Gloria will delve into the structural imaging component, we require also both pre-treatment MRIs as well as regular safety MRIs for ARIA management during the course of patient care. So our goals for today include increasing our ability to use and understand brain scans to support a timely diagnosis of Alzheimer's disease and decide if patients are indeed eligible for treatment with amyloid-targeting therapies, to equip us with skills to integrate protocols for detecting and monitoring ARIA in clinical workflows, and improving proficiency in sharing and discussing imaging results to aid in the coordinated care of patients with Alzheimer's disease. So this brings me to the ATN classification of neurocognitive disorders that was developed back in 2016 as a research framework, but has firmly shifted into clinical practice as we move away from a phenotypical or clinical diagnosis to a biological biomarker-based classification of these patients. It's quite intuitive, with the A standing for amyloid, the T for tau, and then the N for neurodegeneration, which we can image using either metabolic PET or volumetric MRI. Here's a list of the recently released appropriate use recommendations that were put together by the Society of Nuclear Medicine and Molecular Imaging, which highlight various scenarios where either amyloid or tau PET may be appropriate in routine clinical care. Now, in terms of the timeline of how these agents and their reimbursement came about, really one of the key landmarks was the traditional FDA approval of lecanemab or Leqembi in July 2023, when very soon thereafter CMS confirmed that they would be indeed covering these anti-amyloid therapies quite broadly for eligible Medicare beneficiaries. And then just a couple of months later, CMS finally removed a restrictive national coverage determination for amyloid PET and enabled the real-world use of amyloid PET across the country. As part of a decision memo for amyloid PET, again, the coverage with evidence development was removed. And for example, at my institution, we went from scanning about 10 to 15, mostly self-pay amyloid PETs, to over 50 cases a month. We're now consistently scanning between 50 and 70 amyloid PETs a month. So here's just an example of a positive amyloid PET MRI scan. You can see a 3D T1 MP-RAGE on your left with biparietal atrophy that's more pronounced on the left side. In the center is a grayscale amyloid PET image, and you can see that the abnormal accumulation of the radiotracer is not only in the white matter, but it extends diffusely throughout the neocortex, so visually a positive scan, and then you have the fused PET MRI image on the right-hand side. So there are currently 3 F-18 labeled FDA-approved amyloid PET tracers, fluorobeta-peer, fluorobeta-ben, and flutamidamol. They're quite comparable amongst themselves. All 3 have been around for about 10 years now. They have greater than 90% sensitivity and specificity for detecting increased amyloid deposition in the cortex. And you can just see some differences amongst them in the uptake time, dose, and scan duration, as well as visual read criteria. I think one of the important concepts to take away is that amyloid PET is a really excellent exam of negative predictive value, meaning that if your patient's amyloid PET is negative, that really effectively excludes Alzheimer's disease as the cause of cognitive decline. The converse doesn't necessarily hold true, although all patients with Alzheimer's disease will have above normal amyloid burden. Now, there's been increased interest lately in moving away from just a visual binary interpretation to including quantitative measures for amyloid PET in clinical practice. There are a couple of ways to do this. The first one, is to briefly review, is using SUVRs, or standardized uptake value ratios. And essentially what you do using an SUVR is you compute the ratio of tracer uptake between a target region and a reference region. And typically, the reference region for amyloid PET is the cerebellum, and there are various target regions used depending on the software you're using for post-processing. The most interesting scale that I think is going to be very soon routinely integrated in clinical practice is the Centiloid scale. So the Centiloid scale was developed initially in the research setting with the idea that we needed a way to be able to standardize interpretation across different radio tracers, different protocols, different scanners. And the Centiloid scale is an unbounded scale with 2 anchor points, 0 and up 100. So a Centiloid score of 0 is the mean gray matter accumulation in a cognitively unimpaired, healthy, normal control. And then you have 100, which is the mean signal in a patient with mild to moderate AD dementia. This slide here is from a great review that was published by Pemberton's group in the European Journal of Nuclear Medicine and Molecular Imaging, and it nicely highlights some key Centiloid cutoffs versus neuropathology, visual read, some disease progression biomarkers, and clinical trial inclusion criteria. And when I look at Centiloid values clinically, there are some key cutoffs to keep in mind, including that a Centiloid score less than 10 essentially indicates that plaques are absent and it effectively rules out Alzheimer's disease. A score greater than 20 indicates at least moderate plaque burden, and then a score greater than or equal to 50 has the strongest correlation with an AD diagnosis. Now, in terms of utilization of amyloid PET, of course, we use it routinely for a baseline, so for assessing if patients are eligible for treatment. But now that many of our institutions have been treating patients for well over a year, and we have patients approaching the 18-month mark, neurologists are also starting to order amyloid PET to monitor treatment response. So on this scan, you have a couple of examples of various scenarios. So in the top right image, you see a patient who had a Centiloid score of 94 and a positive visual amyloid PET at baseline. And then when they came back to monitor treatment response, the Centiloid score essentially remained stable at 92. So there was no clearance in this case. In the middle, you have an example of a partial treatment response with a patient that went from a Centiloid of 92 to a Centiloid of 30 that's just mildly positive, but still meeting criteria for positivity. So this patient would most likely continue treatment. And then you have, in the bottom right, you have an example of full treatment response with a patient that had a Centiloid of 64 at baseline, and then when they came back for their follow-up scan, the Centiloid went down to 20. So you can imagine in this scenario of monitoring treatment response, having an objective quantitative measure at both baseline and follow-up is quite helpful for a very accurate determination. And just as a side note, the Centiloid is also so interesting to us since the phase 3 clinical trials for both lecanemab and donanemab used Centiloid scoring of amyloid PETs both as their inclusion criterion and then also to monitor treatment efficacy. So in terms of some potential limitations of amyloid PET, interpretations are challenging mostly for patients that have a borderline visual read. So those are patients with Centiloid scores in their 20s, for example. And then there are some other issues, including potential motion blurring that can mimic positivity, similarly attenuation correction artifacts that can mimic positivity, and patients that have significant cortical atrophy that also makes especially visual determination quite difficult. So in terms of communication with referring physicians for amyloid PET findings, of course, it's very important to collaborate with neurologists and other referring physicians. At my home institution, 2-3 years ago, we started a dementia board where we review both interesting and challenging neurodegenerative cases, and that has led to a lot of crosstalk between radiology, neurology, geri-psych, and some other disciplines that are involved in the care of these patients. Standardized reporting templates are also quite important. And at my institution, again, neurologists are routinely starting to ask for the Centiloid value to be included as part of the reports. And then, of course, clinical outcome follow-up is quite important to make sure that communication goals are clearly met. So here's just an example of a potential amyloid PET reporting template. I think these have been developed quite well for the ARIA MRI scans, and there is some early attempts to prepare standardized reports available for amyloid PET standardization as well. So here I have a couple of clinical cases to review with you guys. So first, we have a 65-year-old man who is a candidate for anti-amyloid therapies. This was an amyloid PET MRI. You can see on the left-hand side the grayscale amyloid PET image, the 3D T1 and PeerView in the middle, and then the fused image on the far right. This is kind of a typical nuke med presentation. These are 3mm cuts from the vertex to the skull base. I really like starting from the bottom right at the level of the cerebellum, which is your reference region. So you can see the distinction between the gray and the white matter in the cerebellum in the infratentorial compartment, and then you can see the difference versus the supratentorial compartment as you work your way up. And then this patient also had some quant as well with SUVRs and the Centiloid value as well. And in this case, the Centiloid value was 86, and the global SUVR was elevated at 1.5. This patient did go on for a fluorotaucipir tau PET as well. And you can see that in this example, we have tau uptake in a very classic AD pattern, so involving the parieto-occipital regions. And looking at the SAG, there's involvement of the precuneus and posterior cingulate gyrus as well. So this tau scan is positive in a pattern that's consistent with Alzheimer's type pathology. So here we have the question. So what is this patient's ATN classification based on his amyloid, tau, and MRI images? So you have various answers, and if you can take a moment, go ahead and answer the polling questions, I would really appreciate it. I think most of you chose A+, T+, M+. The A+ is correct, the T+ is correct, and I guess the N was kind of difficult to determine based off of this MRI. We should have also provided volumetrics, but I think the idea was that there was some advanced accelerated volume loss for age as well. Again, this is difficult to assess without knowing the patient's age and also having volumetrics available. So we can move on to the next case, which is a 66-year-old man referred for assessment for anti-amyloid therapies. This patient had an FDG PET first. These are 3D SSPs, or stereotactic surface projections, which is one of the typical ways to assess a metabolic PET. And typically, when you're assessing for Alzheimer's disease, you will look for a parieto-temporal pattern of hypometabolism with decreased uptake in the precuneus and posterior cingulate gyri. I should preface this by saying, in terms of the rainbow color scale used, the orange and red indicates normal metabolism, kind of the yellows and greens are mild to moderate hypometabolism, and then the blues would be severe hypometabolism. And you can see that in this case, you really have a frontal and anterior temporal pattern of hypometabolism, so not exactly what you would expect for Alzheimer's disease. And then looking at the medial projections in the bottom right corner, there's relatively preserved uptake in the precuneus and posterior cingulate gyri, which are key regions typically involved early on in the course of Alzheimer's disease. So the patient went on to get an amyloid PET. We see again the grayscale image on the far left, the T1 in the center, and then the fusion image. And you can see that in this case, what you really appreciate is uptake only in the cerebral white matter and not necessarily extending into the cortex. This patient also had quant as part of his amyloid PET with a normal SUVR of 1.1 and some Z-scores available as well. They also had a centiloid score of -25. And if you recall our cutoffs, the centiloid less than 10 essentially excludes significant cortical amyloid plaque burden. So the patient also went on for a fluorotaucipir PET MRI, and just looking at the available slices that we have here, we really don't appreciate any significant tau tracer uptake in the brain parenchyma at all. So with that, we again have the same question. What is the patient's ATN classification based on his amyloid, tau, and FDG PET images? So if you can take a moment and answer the polling question again, that would be appreciated. Excellent. So most of you chose A-, so the amyloid PET was negative, T-, similar again, and then N+, and correct. In this case, patient with cognitive decline, the patient had a frontotemporal predominant pattern of hypometabolism, like most likely suggestive of a pathology in the FTLD spectrum, or conversely, because of the hypometabolism in the anterior temporal regions, potentially one of the emergent pathologies such as late or PARD, but again, definitively not consistent with an Alzheimer's type pattern. Next question, which is this patient a good candidate for amyloid-targeting therapy? And again, if you can go ahead and answer, I'd really appreciate it. Excellent. So most of you appropriately answered no. Again, the amyloid PET is negative, so there is no role for anti-amyloid treatments in this particular case. So I will go ahead and hand it over to Gloria.
Thank you, and thank you to Dr. Yoshimi Anzai and for PeerView for putting this session together. So thank you, Anna, for that amazing start with amyloid PET. And now we're going to talk about MRI in the area of amyloid-targeting therapies. How do we visualize for treatment eligibility and safety? So this is a very dense slide, but the key thing for all your practices is to remember consistency and standardization. And so you can see this pyramid for the MRI protocols. In the ideal world, we would scan our patients on the same field strength, the same vendor, the same scanner model, et cetera. But that's just not realistic in our very large academic and private practice systems. And so what I tell people is it's okay to scan these patients on 1.5T versus 3T. But if you start off at 1.5T, just keep them consistent. Keep them on a 1.5T the whole way through monitoring. And the reason for that is you can imagine there's different sensitivity especially for ARIA-H, looking for these little microhemorrhages. So you don't want a situation where you have a certain number of microhemorrhages on the 1.5T, the patient then goes on to a 3T and you see more microhemorrhages. And you don't know if it's because of ARIA or if it's just the increased sensitivity of your scanner. So whatever you end up choosing, try to stay consistent in terms of field strength, try to have a consistent standardized protocol on all your scanners as well, so you can monitor the patient appropriately. And we have a lot of these sequences on the ASNR website, but you can see them here. So the key sequences to detect ARIA are gradient echo. You can use SWI, but the clinical trials used gradient echo, a T2 flare sequence to look for ARIA-E, either the edema or the effusion. And typically we include diffusion-weighted imaging because it's very fast and excludes all the common sort of acute things that we would worry about in neuroradiology. So yes, just try to stay consistent with whichever field strength you are and keep the same protocols. So what are we looking for before putting these patients on therapy? Well, the key things are to report on anything that could exclude the patient from therapy. So essentially anything suggestive of CAA, so cerebral amyloid angiopathy, that's going to put them at higher risk of ARIA. So larger cerebral hemorrhages greater than 1 centimeter, more than 4 microhemorrhages. That's why it's really important to very carefully count the number of microhemorrhages on your baseline scans, superficial siderosis, vasogenic edema, and anything else that could increase the risk of hemorrhage, an aneurysm, vascular malformations, et cetera. And these should be in the report very clearly because the neurologist needs this to make sure the patient's appropriate for therapy. So there are 2 now FDA-approved therapies out on the market, lecanemab and donanemab. They have different monitoring schedules. And so just keep that in mind. Ideally, at your institution, there's someone that can coordinate all these MRIs for these patients. So at our institution, we have a dedicated nurse practitioner who follows all these patients. She schedules all the MRIs at these intervals and makes sure that these patients come back. But just know these 2 monitoring schedules so the patients don't fall through the cracks. So in terms of ARIA risk factors, so ApoE4 is a key one. So ARIA is more likely to occur with these ApoE4 carriers, especially the homozygotes. The homozygotes especially are at very high risk. The dose matters. So higher doses, you have increased ARIA risk. And also the majority of ARIA events happen early. So it tends to be the first few months that you see ARIA. Once they've been on it for a while, usually sort of the risk sort of tapers off. But really the first few months of monitoring are very crucial. Again, anything that's suggestive of underlying CAA could be a risk factor for ARIA. Ischemic white matter changes, so grading the white matter in some way, if you use the Fazekas scale or if you mild, moderate, severe, to somehow put that in your report, and then use of anticoagulation. So there is a way to grade ARIA, both ARIA-E and ARIA-H. And so you don't have to commit this to memory, but have a ballpark number. Remember 5 and 10, that's sort of how the moderate and severe, that classification kind of separates out. And so for mild ARIA-E, it's flare hyperintensity in one location. It's typically less than 5 centimeters. For moderate ARIA-E, it could be more than one area, but they're still smaller than 10 centimeters. And for severe, it's larger than 10 centimeters, and it could be in more than one location. In terms of pitfalls, you should know what are some mimics for ARIA-E when you're reading these scans. So classically, supplemental oxygen, you can have this high signal within the sulci, so you need to make sure to check for that if you see that. ARIA-E can also look very similar to CAA, especially inflammatory CAA, so there's an image on the right. So this was actually a patient that didn't have a history of being on this therapy, but had that sort of classic appearance, the parenchymal edema, et cetera. Press can mimic ARIA, and so there's even some notion, some people think ARIA really is press. There's some debate about that. Ischemia, obviously, you want to rule out. That's why we have the diffusion-weighted sequence, and CAA, as I mentioned. But the key thing in your institution is to make sure you have that history of amyloid-targeted therapy, either in EPIC, or if there's a way to highlight it in your history when the neurologists are ordering these studies. It's important to know that history when you're reading these studies. So similarly, ARIA-H, you have a grading scale. Again, 1, 5, and 10 is sort of what I keep in mind. So for mild, 1 to 4, new microhemorrhages on therapy, that would be considered mild. Moderate, once you get to 5 up to 9, so not quite 10, that would be considered moderate. And severe is greater than or equal to 10 new microhemorrhages. So again, the number really matters. And so that's why it's so important to stay consistent with your protocols and your scanners, because really one new microhemorrhage could put you over from 4 to 5, from mild to moderate. With siderosis, you're looking at how many areas of siderosis you're seeing. So either 1, 2, or more than 2 for mild, moderate, and severe. So again, we're all radiologists. We know to look for mimics. So just make sure, especially areas around the skull base are tricky. You can have susceptibility artifacts there, around the temporal bone. So just make sure to check if those are artifacts or if those are real microhemorrhages. The phase encoding direction around the vasculature, sometimes you can get some artifacts around there. So check for these types of artifacts when you're reading these cases. So this is really key. So because there is this sort of standardized way of monitoring these patients, and it really makes a difference in terms of management. So for example, typically when there's moderate ARIA, neurology will actually stop the drug. They'll stop the drug and they'll order more monitoring MRIs to see if the ARIA is getting worse. So it really is a management decision, which means that timely communication to a referring physician is really important. So our institution, we have these bi-weekly multidisciplinary conferences between radiology, neurology, neuropsychology, and we talk about a lot of the more challenging cases. Do we put them on therapy? Do we not? We look at some cases of ARIA. We'll look at the PET scans. So that's sort of our routine in the background, multidisciplinary conference to go over cases. But you should also have a way to communicate with your referring physician for these management type decisions. So if it's mild ARIA, usually they continue on the drug, so that you could call the office, talk to the neurologist nurse, have it in the report. That's usually okay. For moderate and severe, as I mentioned, usually the drug is stopped. So you want to have some sort of physician-to-physician communication, either calling the neurologist yourself, having some sort of EHR chat to make sure they've received that, because it could make a difference in terms of stopping the next infusion. Online on the ASNR website, there are protocols and templates that you can download. At our institution, we do have these reporting templates because it just makes it a lot easier for neurology to see these, and it's very clear, is there ARIA-H or not? Are there new microhemorrhages or not? So using the templates is a great way to communicate. And there also are templates built into PowerScribe if you want to download that off the website. And just moving on, there are many vendors here. Here at ASNR, and there's so many of these new tools being developed every day in terms of automating a lot of these processes. Just know that there are tools that are out there that are trying to help in terms of quantifying the longest access for these lesions, the number of sites that are involved, changes in lesion volume for ARIA-E, for example, and they can actually automate the scoring so you don't have to keep track of that table. Same for ARIA-H. There are vendors out there with these sorts of reports and templates that can automate all this for you. I'm not going to go into detail, but feel free to talk to the vendors outside about some of these tools. So we're going to run through a bunch of cases right now. So here's the first one. That's the first case. So you can see the area of abnormality on the T2 flare image. On the bottom, so we have T2 flare, we have the SWI. On the bottom, you have diffusion and the ADC map. And the question is, what is that abnormality? Almost everyone picked ARIA-E. Yeah, I should have mentioned, these are all on therapy. You're absolutely right, I should have given that to you. But yeah, assume they're on therapy. Okay, so yeah, you guys were right. This was a case of mild ARIA-E, and I showed you the bottom to show that this was not acute infarction. Okay, and this is the next question, and you can see the area of abnormality pointed out with the arrow. This is a little bit harder because not only are you identifying what this is, but what type of ARIA this potentially is, and yes, they're on therapy. So indeed, so that arrow is actually pointing to this small little area of sulcal effusion. It looks like in the central sulcus. I guess I gave it away, there was no arrow on the SWI, but yes, this is a case of mild ARIA-E. Here's the next question. So you can see now there are 2 arrows. So again, not only seeing whether or not there's ARIA, but also grading it. So you can see there's this little area of T2 hyperintensity just along the bottom of that sulcus in that right frontal lobe. And that actually corresponds, that little deep part of the sulcus is also a little bit of siderosis. And you can imagine flipping through all these images, it'd be so easy to miss, right? That tiny little area along the sulcus. But that's why it's important to really look at these cases very carefully. So indeed, this was correct number 4, mild ARIA-E and mild ARIA-H. And here's your next question. So some people think ARIA-E, some people think both ARIA-E and ARIA-H. And I heard someone yell out press. So it does look like press, doesn't it? It has that same sort of distribution, and this is why there's a lot of controversy as to whether or not ARIA is really just a form of press, right? So that's still kind of, being sorted out, but indeed it does sort of look like press. In this setting, we call it ARIA-E. There are 2 sites involved here. They're both less than 10 centimeters. On the SWI, those are actually just veins. They're not actually siderosis or microhemorrhages. So this was a case of moderate ARIA-E. And here's the next question. Excellent. So it's a little bit tricky here because I guess I had to make sure you guys could count how many microhemorrhages there were. There were actually 5. Yeah, not 4. But do you see how miscounting 1 can just completely change the patient's management, right? It changes them from a mild where they can continue on the drug versus moderate where they would have to stop the drug. And so in this case, it was a cluster of 5. This was moderate ARIA-H, and the patient did have to suspend the next infusion. Okay, so in terms of key takeaways, as you all know, these new disease-modifying therapies are really changing the landscape of neuroimaging for AD. We as radiologists are now key players in the patient management. It used to be that dementia cases could sit around on the list for days, right? That's no longer the case because oftentimes the patient comes in for their scan and they're getting infused the next day. So we are involved in that active management. We do need to communicate in a timely fashion to our neurologists to make sure the patient's getting appropriate therapy. And as I mentioned, you can see how different the management is with just a difference of 1 microhemorrhage. So again, having consistent, standardized imaging protocols is really important. Making sure that these patients are getting all their follow-up MRIs ordered, scheduled, performed is really important for these patients. And then having some sort of standardized reporting for both amyloid PET and for MRI makes it a lot easier for referring physicians to actually manage these patients appropriately. So with that, I thank you for your attention. So I think we have a little bit of time, right? We have a few more minutes, so we're happy to go over these questions that were sent to us. So should we just start from the top? Yeah, why don't we start from the top? Okay. Sure. So Dr. Pinter asked us, does ARIA-H occur without ARIA-E? That's an excellent question. And so ARIA-H, if you recall, with microhemorrhages, we can see spontaneous microhemorrhages in older people just in general. So it's really tricky in the setting of these anti-amyloid therapies. Is it microhemorrhage just from their baseline vascular disease, or is it microhemorrhage because of ARIA? And we don't have a great answer to that. I've asked a lot of people at different institutions, and the consensus is, even if it's a microhemorrhage, let's say we've seen some in the cerebellum, right, where there is no amyloid. Even if you don't think it's related, you have to report it as ARIA-H because it's in the setting of this medication. So yes, I have seen ARIA-H without ARIA-E. I don't know if you want to. Go ahead.
I can go ahead with the next question. So can PET distinguish between AD plus late versus just AD or late? How is vascular dementia identified on PET? One of my favorite topics for those of you who are not familiar with LATE, LATE stands for limbic-associated age-related TDP-43 encephalopathy, and it's a form of neurodegenerative disease that typically presents with an amnestic syndrome that clinically tends to mimic Alzheimer's disease. And one of the key distinctions is that it typically happens in the high elderly population, so patients in the high 70s, early 80s and up. And its public health impact is actually thought to approach that of Alzheimer's disease. So, I think for this distinction, FDG PET, so metabolic PET, is quite helpful. Patients with Alzheimer's disease, as we discussed earlier in the talk, typically have a parieto-temporal, so posterior predominant pattern of hypometabolism with involvement of the precuneus and posterior cingulate gyri. Meanwhile, patients with late typically have both advanced atrophy and hypometabolism in the anteromedial temporal regions. Part of the question is also about distinguishing patients that have both pathologies at the same time. And in terms of that, co-pathology and mixed dementia is one of my favorite topics. And I also always like to quote statistics from one of the community-based autopsy cohorts that show that about 80% of patients with cognitive decline will have at least 2 pathologies. 60% will have 3 or more pathologies. So I think in daily practice, it's really important to remember from our obsessions of making a single diagnosis that many of these patients are heterogeneous and will actually have multiple co-pathologies at the same time. And then the final question is, how is vascular dementia identified on PET? And I think as far as vascular dementia and vascular burden, MRI imaging is a far more powerful tool. So typically, in my practice, we integrate both the PET findings with the structural MRI findings. And in terms of vascular dementia, MRI imaging is much more helpful for a diagnosis.
And we can just quickly run through other ones. So someone asked about centiloids, are they applicable across all PET tracers? The whole idea, or just amyloid, the whole idea of centiloids is it's consistent across tracers. It's consistent across platforms. It's consistent across vendors. So it's a way of standardizing quantification of amyloid across centers so you can actually use it in these large-scale trials. So that's really the whole point of centiloids, and you can follow up again with that same scale. How do you deal with visual and quantitative mismatches?
Maybe, or this one about the advantages of quantitative versus qualitative assessment. So go
ahead.
Yeah, I'll take this one. So what does quantitative analysis in amyloid PET really add over a qualitative visual assessment? Twofold. Firstly, we're taught visually that the amyloid PET is either negative or positive, but depending on your referral base, up to 15 or even 20% of cases may be visually indeterminate, so borderline. And having an additional quantitative measure really helps kind of make your final assessment. But perhaps more importantly, in the current era of treatment, the quantitative analysis is really crucial for firstly enrolling the appropriate patients and then allowing you to monitor treatment response on the follow-up scans.
Yeah, and also related to that, how do you deal with visual and quantitative mismatches? Like visually looks normal, but then there's an area of abnormality. So that's something my postdoc Mohammed, we're publishing a paper right now, it's actually accepted in AJNR that did precisely that. So there's actually very high concordance between visual assessment and quantification with centiloids. It was 97% with florbetaben. But exactly, it wasn't 100% because there were cases where visually there was a focal area of amyloid that wasn't picked up by centiloids. And for those, I tell my neurologists, there's a focal area, usually in the temporal lobe, that's something we need to follow. And then you sort of have to put the picture together, often with tau PET, FDG PET, to decide whether or not to treat that patient. I just want to thank the person who asked, could ASL-MR be used to identify amyloid for biomarker confirmation prior to treatment? That's something near and dear to my heart. So we are looking into that. There have been a couple papers that we published. We've actually found that ASL seems to be more closely correlated with tau than amyloid. So we're exploring if we can use ASL to actually predict where the tau is. But thank you for that question.
I think we just got signal that we are out of time.
And I think we're done.
Yes.
Okay.
We
Thank
saw
you all
signals
for the
from back.
questions.
Thank you for the discussion.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported by an educational grant from Lilly. To access all materials for this activity, visit peerview.com/CEH860.